Okay, so this is the third part of our exploration into tropical disease, but today we're going to be talking about malaria exclusively. So one disease. It's so complicated that it gets one disease, one whole presentation. We could easily do a full course on malaria, easily, or even full course on one specific part of malaria, and still have plenty to explore, for sure. So, happy to introduce this to you. Let's go. So, as we saw before, malaria was prevalent even here in the United States up until really very recently in human terms. You can see in this picture the last decade that malaria was found in each of these regions of the world, but it still persists in the developing world. There's approximately 228 million cases worldwide back in 2018. Things haven't changed too much since then. 93% of these cases occur in sub-Saharan Africa. A quarter of all malaria cases around the world occur only in Nigeria even. There are 6 countries in sub-Saharan Africa that account for 50% of malaria cases worldwide. Other areas of the world like Southeast Asia and India also have problems with malaria, but not like sub-Saharan Africa for sure, and we're going to talk about why. 450,000 deaths worldwide every single year, and most of these are kids under 5. What is malaria? Malaria is a human blood disease. It's a human blood parasite that has a complex life cycle that includes mosquitoes, humans, and comes from the genus Plasmodium. And we're going to talk about the different species of Plasmodium in a bit. Symptoms of malaria include fever, chills, shaking, headache, muscle aches, tiredness, nausea, vomiting can also occur. Malaria can also cause anemia and jaundice because of the loss of red blood cells. And if not properly infected, it can infect the kidney and cause mental confusion, coma, and death. So here's the life cycle of malaria from the CDC. It's extremely complicated, not the least reason of which is because it includes 2 independent organisms, humans and mosquitoes. And you can see that it has stages that it goes through within the mosquito, and it has stages that it goes through within the human too. Clinical picture is in the acute form of the disease, non-severe acute febrile disease can sometimes progress to what we call cerebral malaria and cause death. There's also the chronic version of these, which isn't really a chronic infection, but it's just because people are being reinfected so many times that they're infected almost all the time. Can result in chronic or recurrent asymptomatic infection, anemia, developmental disorders, transfusions, death. Infection during pregnancy, vertical transmission from mothers to infants, low birth weight, increased infant mortality. Humans, clinical picture, impacted by acute febrile attacks. You can see in this picture, there is the cold stage, the hot stage, and the sweating stage. Malaria goes through all of these cycles, and you also have periods where you feel relatively well, and then all of a sudden it comes back. One of the hallmarks of malaria is that it goes through these cycles. Parasites. There are 4 different human-transmitted species of malaria. Plasmodium falciparum occurs almost exclusively in the sub-Saharan African continent and is responsible for most cases, the vast majority of malaria cases, and almost all of the malaria cases of mortality. Not all, but mostly all. Plasmodium vivax, which is considered to be a cold weather malaria, and it's relatively benign, generally less severe. Majority of the burden is in East Asia and Pacific region. There's chronic liver forms. So you can be infected now, and then decades later it can come out to cause illness again. The reason for this is falciparum malaria occurs around the equator, where there's no winter. There's rainy seasons and dry seasons for sure, but there's no winter. So in whole endemic areas where mosquitoes are present almost year-round, there's no incentive for the pathogen to have a place to hole up for the winter. Vivax malaria, on the other hand, occurs in colder areas like India, for example, northern India, Afghanistan, where there is a winter. Occurred in Europe, North America. The reason for that, what am I saying? There's a winter. So, sorry about that, there's a winter. So, the pathogen has to have a place to hole up for the winter because during the winter there are no mosquitoes. So what it does is it chills out in your liver, waits for spring to come around when the mosquitoes come back out, comes back out, and transmission continues. There's also two other human malarias, Plasmodium malariae and Plasmodium ovale. These are found less, but they're there for sure in different regions of the world. And there's also a zoonotic malaria called Plasmodium knowlesi, which is transmitted from monkeys to humans. There's some scant evidence out there of human-human transmission for sure, and there's a concern about it, but right now it's considered to be a zoonotic malaria. Impacts in human host. Incubation period generally lasts 7 to 14 days, up to 40 plus, or months even for Plasmodium vivax. Infection can include febrile illness, and there's asymptomatic cases out there and living in endemic regions, more severe in unexposed people, and maybe severe in Plasmodium falciparum malaria. Now, vivax is why you can go somewhere, for example, go to India, go hiking, come home, you're fine. A couple weeks later, you start getting fevers and feeling sick, wonder what's going on, and your doctor doesn't know what's going on because the incubation period has just been so long in that case. So of course, report to your doctor where you've been and what you've been doing. Vectors. One genus of mosquito transmits malaria. These comprise 70 species of Anopheles can transmit, 20 plus of which are major vectors. There's what we call incompetent vectors and competent vectors. Some mosquitoes are better at transmitting malaria than others. The pathogen has evolved to take advantage of certain aspects of the mosquito to allow it to be transmitted more efficiently. Anophelines rest at a 45-degree angle. If you're out in sub-Saharan Africa and you're hanging out outside and a mosquito lands on you and it's sitting like this, it's an Anopheline mosquito and you should be a little bit concerned depending on where you are. Culesines, 80s mosquitoes, they generally lie flat. Anophelines, 45-degree angle. That's how you tell the difference. Anopheline mosquitoes like clean water. Preferably pools after rains or clean streams, slow streams, rice fields, all these kind of areas. They generally speaking do not like dirty water to reproduce in, but this is changing. For a long time, there was very little urban malaria out there, but now there's a very concern because some mosquitoes are actually adapting to be able to reproduce in dirty water and take advantage of urban environments where there's more people to allow them to have more blood meals, to allow more opportunities to reproduce. Global high-risk groups, pregnant women, maternal anemia, stillbirth, spontaneous abortion, low birth weight, neonatal death. These are all problems. Children under 5, where the vast amount of mortality is. And then people with HIV/AIDS. Co-infections are common, and HIV increases the risk of serious complications. Malaria interventions. Most common interventions include four things. First is indoor residual spraying, where teams come to your house, they spray your walls with DDT. DDT is famous in the United States, most notably because of Rachel Carson's The Silent Spring, written back in the 1960s, I believe. During the malaria elimination programs of the 1940s and 50s, DDT was used widely as a form of vector control to kill mosquitoes in fields. But what they found quickly was that mosquitoes developed rapid resistance to DDT, and DDT was having negative impacts on the environment. And Rachel Carson wrote The Silent Spring, exposed this, and led to the banning of DDT and started the environmental movement. DDT is still approved for use of malaria control within the home. It is not approved for agricultural use. So you still see teams in sub-Saharan Africa spraying walls. The idea which is mosquito comes into your house at night, bites you, takes a blood meal. Well, blood is heavy, so it has to go rest on the nearest vertical surface and expel all the liquids and all the stuff it doesn't need for your blood, and then flies away into the night. If you spray the wall with DDT, the mosquito, mother mosquito, lands on the wall and she dies. Benefit of that, she can't infect anyone else with the pathogens that she might have just picked up, and also vector numbers are decreased because she can't reproduce either. insecticide-treated bed nets. Very, very important. Insecticide-treated bed nets are like any other bed net you sleep under that prevent mosquitoes from biting you at night, but they are impregnated with an insecticide. Permethrin, deltamethrin, all these different kinds of insecticide, and the idea is mosquito comes in at night to try and get its blood meal, it lands on the net, there's insecticide there, and it dies. So it can't infect you, and it also can't go reproduce. So it's a double benefit there, protecting yourself and the community at the same time, kind of like a vaccine. Rapid diagnostic test. Prompt diagnosis and treatment is essential to controlling any infectious disease. Rapid diagnostic tests are cheap. You can get them for like 50 cents or $1 at any pharmacy in sub-Saharan Africa. And you can get your result of whether you're infected or not within minutes. Very easy. So you go buy one, it's got a little lancet, blood sample, put it in the hole, positive, negative, then you do whatever you do from there. You either take malaria medications like artemisinin and combination therapies that you see here, ACTs, or figure out what else is wrong with you. ACTs, one of the best malaria medications in history, replaced the earlier medications like quinine and chloroquine, which quinine is still used for severe malaria. It's based on a plant from China. It was used historically thousands of years ago for malaria, for headaches, fevers, these kinds of things, and is now found to be one of the best, medications against malaria. So definitely sleep under your bed net, prevent yourself from getting bit. If you get bit, and if you come down with a fever, go to the pharmacy or the doctor or whatever, he'll give you an RDT, test positive, take your ACTs for sure. Now, big challenge here is access to IRS, access to ITN, access to RDTs, access to ACTs. Access to medical interventions is essential. If people don't have access to it, they can't get it and can't get the benefits to it. So think about that for a while when you think about these interventions. What are the barriers for people getting the medicines and interventions they need? Bed nets last like 5 years or so. In some cases, they can last less, depending on how they're used. They're a core component of integrated vector control all around the world. Highest cost-efficacy ratio for malaria intervention. ITNs can reduce malaria transmission by up to 90% and lower by up to 44% all-cause mortality in under 5 children. ITN uses during pregnancy reduces all-cause maternal anemia with fewer premature births. IRS, we've already talked about IRS, needs to be reapplied 1 to 3 years. So when we talk about access, can people get access 1 to 3 years? Is that program available? And this requires the buy-in of governments and health systems to make this happen. And that doesn't always happen in all places in the same way. PPE and vector control. So screens on the windows, very simple. Not practical in places where people don't have a lot of money to pay for things like screens on the windows, but where it is possible, it's effective at controlling access of mosquitoes to humans. Vector control, fogging with insecticide, larvicidal fish, larvicides in ponds, all these things to control vector numbers in the community. Prompt diagnosis and treatment, talked about that. Need to diagnose to find the cases before we can treat them. If we can't give prompt diagnosis, we miss cases and they go out and contribute to transmission. Diagnosis, truth be told, it's often presumptive. People come in with a fever, child comes in with a fever, doctor prescribes malaria meds immediately. It's just the way it goes. Most people don't actually get a test. The first line source of medical care is actually the private sector. People go to pharmacies or whatever, and they get paracetamol or whatever to treat malaria, and then they move on, so we miss cases all the time. But when there is diagnostic facilities available, light microscopy is one way of doing it, where a person takes a sample of your blood, they look in the blood to see if there's parasites present or not. If there are, they treat you. Places that don't have that can use RDTs. Asymptomatic cases are important in transmission of any infectious disease, but particularly in malaria. It's not entirely well understood how much asymptomatic cases contribute to community transmission of malaria, but it can't, I would be surprised to think it's nothing. There has to be a role there. So, problem with malaria is immunity builds over time as a result of repeat infections. But people who have been infected repeatedly have malaria. If you test them, it will be positive, but they don't have any symptoms. So they're not motivated to go to the facility to get treated. This is, again, sort of test and treat. If they don't get the test, can't treat them. So you'll go to some place like Western Kenya, for example, in some areas that are holo-endemic for malaria. You see people walking around just fine, all over the place, right? But if you give the malaria test, you will find a lot of positives out there. And you will find a lot of people who are anemic as well. Microscopy is an experience, it requires experience. People who do it for a long time are better at it than people who just come in. So it really depends, you know, how good your microscopist is. There's some people out there who are really, really good at it, and there's some people out there who aren't so good. And the reliability of your diagnosis will depend on this. Transmission classifications. High transmission, where if you test children and you find 50% or more positives, high transmission. Moderate transmission, 10 to 15%, 50%, and then low transmission. And these are often areas where malaria is seasonal. But the problem is when you talk about high, medium, low, you're not talking about the same dynamics. The ages of the cases that you'll see will be different. So in high transmission areas, you'll see lots and lots of children with their positives. You'll see high child mortality. But you won't see as many adults. But in low transmission settings, you'll find that cases are spread evenly over the age groups. And these can have different implications for not only transmission, but also morbidity and mortality. Immunology to malaria is complex. You're generally born. Within 8 months, your maternal antibodies wane and you're susceptible. So deaths tend to be the highest in young children. Parasite rate tends to be high in children a little bit older than that, the ones who are able to make it to that age. And then specific antibodies go up over time. Now, if you are routinely exposed to malaria, to Plasmodium, and you leave and go somewhere where there is no exposure to that for several years, and you come back, you've lost immunity to that. Immunity to Plasmodium only lasts a short time. It depends on repeat infections over time. Different age groups in different transmission settings will have different outcomes. There are vaccines in production right now. Not really going to talk about this for now. But there are vaccines in development. Some are being tested, but generally very expensive and require extremely strict dosage schedules and don't last very long. Barriers to global progress. Well, this is like, we could have a whole class on this for sure. Why does malaria persist? We got rid of it in the southern United States. We got rid of it in places like Italy, Spain. But it persists in other parts of the world. And the question is why? Despite the fact that we have tools, we have interventions, we have vector control tools, we have medications, we have advanced treatments, we've got all these things, malaria persists. And why does it persist in the areas where it does? There's all different kinds of factors here. First, biological factors. Vectors can be more competent in some areas than others. So for example, in North America, many of the vectors weren't as competent at transmitting malaria as vectors like Anopheles gambiae in sub-Saharan Africa. Environmental factors. What is the surrounds of where people live? One of the reasons that malaria faded out in the United States was a move from people from swampy environments to urban environments. So we were lowering the population in swamps and increasing the population in cities where they're less exposed to the type of mosquitoes who would spread malaria. Cultural factors. So, for example, we were talking about insecticide-treated nets. Well, in indigenous areas in Panama, people sleep outside. So insecticide-treated nets don't work there because there's nowhere to hang them up. It's a real problem. One intervention in one area will not necessarily work in another area because of cultural factors. Socioeconomic and political factors. Well, we could have a whole class on this for sure. Money. Can people afford the interventions they need? Can they afford the meds they need? Can the health system afford them? Is the health system committed to providing them? Are governments backing up their health systems to provide malaria interventions, treatment, and care? All these are big open questions. The point here, the moral of the story is malaria is a very, very complicated disease. It's a complicated life cycle, but also a socially complicated disease and requires more than simply just medications. It requires all the things that lead up to medications. It requires improving people's housing conditions. It requires buy-in from governments, all these different things. And that's all I want to talk about today. But what I want you to think about when you're thinking about malaria is think about the complexity and think about if you were to design interventions, how would you implement them? What would you design them around? What part of the infection chain would you design them around? How would you go about it? And that's it. Yeah. So if you have problems and you want to contact me, please do, because I am here to help you.